Morning, everybody. So I'm going to give you a 20-minute update. So already a disclaimer up front is that I will not be able to cover all the topics of the guideline within 20 minutes. And I will explain to you why in the coming slides. So it's still not working. There's also... I don't mind doing it like this, but it's good that we know that it doesn't work.
The pointer is working, but
yeah.
you could not finish, so maybe you have to do that now.
No, I will just do it like this. But so already the previous guideline was from 2019 and was then headed by Professor Kasim Javed from Oxford. And a lot of things have been changing. It's already 6 years ago. So despite the fact that we're still always talking with each other that we need more research for FDMES, I do think with this guideline we also saw that a lot of research has been done in the latest years. And in that time there was one big paper, of course, with a lot of different disciplines coordinating that and being integrated in that. And I have to applaud Kasim for the many, many versions that he made. I think you ended with 55 or 60, something like that. Because, of course, when you collaborate with such a big group, everybody wants to have a say. And some things are also different because, especially in fibrous dysplasia, where there aren't a lot of trials ongoing. So that means that everything that you will put in the guideline will not be the highest level of evidence. So we usually consider the highest level of evidence if there are any randomized controlled trials. But in the case of fibrous dysplasia McCune Albright, there are hardly any. So that means that there's also a lot of discussion ongoing between experts. So this has been our timeline so far. So we started to draft the old revision in the 2023 meeting in Silver Spring, Bethesda. And then we did an extensive literature search. So one of my PhD students, Owana Bulaikon, who wasn't able to make it today, but did a lot of groundwork for that. Then we did the Delphi rounds. So for those of you who don't know what a Delphi round is, but that's just we make a survey, a questionnaire, and then we send it out to the experts, and everybody has to provide a number between 0 and 10 on how much you use certain things or what's your common practice. So it's a very structured way of getting input from everybody and also to shift a bit between local variations, because some things might not be possible in some countries where it is possible in other countries. And that is a validated method of doing guidelines. Then, of course, we were not agreeing on everything. So we had online discussions, a couple of them, and then we were starting drafting the manuscripts. And because there was so much extra information than in the previous guidelines, we in the end decided to go from 1 paper to 3 papers. Making a difference between the endocrine and the extraskeletal complications for fibrous dysplasia McCune Albright, to make a dedicated section for the craniofacial part, because a lot of the oromaxillary surgeons, but also ophthalmologists, will not be reading the regular bone magazines, and it's easier to highlight a single session for them in a single article. And also there was already so much literature there that it could easily be a standalone article. And then we, of course, had a more bone-related topic with input from the orthopedic surgeons. We didn't throw everything away, of course, from the old guidelines, so we kept on performing everything in a multidisciplinary way. We made sure that we had clear definitions and also had sections according for the diagnosis, treatment, and a solid structure for the papers. And in the new guidelines, we did do some redefining of certain things that we all agree on, but are currently in the medical field not already common knowledge. So like just sharpening the definition of the disease, but also the changing of the name for the café au lait spots, because if you don't have a light skin, café au lait spots don't appear like café au lait spots, so we try to make it more inclusive. We also, of course, included the latest research, and what is new in our guidelines now is that also that we have some evidence-based statements covered with the literature backup. So I'm shortly going over some of the bigger changes, and it was impossible to highlight all these tables, but you have these really boring tables, but essentially they all summarize what we did during the guideline papers. So what you see there, we have the Delphi consensus in the, that people agreed on it, and then we have the level of evidence, so that is part of the literature search, that you look at it, how many studies were done on that particular topic, and do we think it's a very high level of evidence or low? And it's not that everything is not good, it's just that there isn't a lot, like I said before, there aren't as many randomized controlled trials, so almost everything is observational studies, that we just look very closely at our patients, that it automatically comes in a low section and even goes to very low if it's not that many. And if there's no research available or has never been done because everything is very logical, then we call it good clinical practice. And that's just what is also agreed upon in the Delphi consensus. So that's a bit how we did it. So some of the things that we sharpened a bit is the definition of fibrous dysplasia, McCune Albright syndrome. So a lot of the things remain the same, of course. We're not totally going to change the definition of the disease, but I think the main thing is I put it slightly below here, is the intramuscular myxomas, which are the benign soft tissue tumors that can also be accompanied in fibrous dysplasia, McCune Albright syndrome. It's also called Massabro syndrome. But it's very confusing because it's still the same mutation that is causing the problem, and why would you call it a different syndrome? While it is a mutation that is located outside the bone, so usually people with Massabro syndrome also have other extraskeletal manifestations of the GNAS mutation. So therefore we put it now in that people also with myxomas are considered to have McCune Albright syndrome. But then you would say, well, then it's logical that you might also want to skip the definition of Massabro syndrome. But there you can see we did not agree, so that what descent means. So we now still put it in, but then in brackets. So you have McCune Albright syndrome, then you have the list, like over here. And then you just put it under in brackets that intramuscular myxomas are also known as Massabro syndrome. But it's good that we start the bus going, and that when you have these myxomas, that there might also be, has to be some effort to be done to look at different manifestations of the GNAS mutation outside the bone. And perhaps in the next guideline revision, we can officially drop the term. But a lot of people, and especially a lot of orthopedic surgeons, know the term quite well, so it's a bit more difficult. So that's why we kept it in. For the diagnosis and initial investigations, we also had some conversations on what would we advise for people to do. So we gave some practical advices, taking into account that in many countries some things might be available, some things might not be available. A lot of these things were done we could do and decide on quite quickly. And also this comes from the second part of the exoskeletal manifestation. So every article has its own particular section on what we advise for that particular diagnosis, which also means that in the end, because I will come back on that later, is that we need to revise our patient guide. Probably, I think it will be 3 guides as well, dedicated more to disease-specific sections. So it's very difficult for me to read my slides over here, so that's why I'm leaning a bit back off sometimes, because just when you're a speaker later on and your slides are white, I would advise you to take a different background. It's easier. When we look at here, so for this part, this is the also the last part of the exoskeletal manifestations article, is that we also paid some attention on when endocrine complications might alter bone activity. So we made some statements there that in case of a lesion that is growing after puberty, or when you have progressive craniofacial disease, that there needs to be more attention also towards repeated endocrine testing. So these things we also try to back up not only with the Delphi consensus but also with the literature search. If we look at the bone part, so I think the only thing that I would like to highlight from the particular evidence table is we have, I think, one thing that we had a very high level of consensus with, because that is the only topic. There were 2 randomized controlled trials, is when people want to treat fibrous dysplasia of bone with oral bisphosphonates. So one was the trial performed by the NIH with Michael Collins and Alison Boyce with alendronate. And then the other one was the paper from the trial from Roland Chaperla from Lyon, who did it with risedronate. And both trials were negative. So I think the only good advice that we can give with a high level of evidence is that people should not get oral bisphosphonates for the treatment of fibrous dysplasia. Of course, when you have also osteoporosis and you don't need treatment for your fibrous dysplasia, it's totally fine to get oral bisphosphonates. But when you're having pain or lesional growth, there's no reason to give people oral bisphosphonates. So I think that's also quite a strong advice, which we now can really back up with the high level of evidence, and we hope that this also will make it through to the next medical world. Also, what we think is still remains very important is that there's always a lot of discussion ongoing on how safe are bisphosphonates and what about pregnancy. So we try to look into that into literature. We also define some topics, of course, for the next coming years that we think are very important to pay attention to. So especially in the terms of pregnancy, with past medication use, but also on what are the outcomes of pregnancies in females with fibrous dysplasia, McCune Albright syndrome. I think we have a lot of work to do because basically what we can tell now is just Delphi consensus and good clinical practice. So that means there will be a high variation, which is not wrong. It's only good to realize for yourself that then you might get different advices from different persons. Just to skip it a bit sooner because I think we need to... Oh, still okay? All right. So for the other part is that what we think is also very important, which also made some discussions, especially among the orthopedic surgeons that we had on board for the guideline changes, is that we advise against curettage of the lesions. So that means that sometimes where there are people with fibrous dysplasia lesions of bone, they might get the advice that the lesion can be scraped out and be scraped away. Of course, technically that's possible, but it will grow back. So that's the reason that we don't advise people to get this particular type of surgery. In the previous guidelines, we also shortly mentioned it, but I think it's good that we made now a very strong statement about it, because you still see that people found that there were some holes within the previous guideline where they said, well, we could still advise to do this, but we think it's important not to do it anymore. Also, we provided, when possible, some technical advices regarding how to treat a fracture. So if it's possible, then you try it with the intermedullary nail. But of course, due to the deformity, sometimes it's not possible, but it's good that it is there, that at least there is some sort of first step that people can think and consider. And also that we think that with bone grafting, there are also some bits and bats there which are more integrated in depth into the text. But I think we try to make some advices possible, when possible, for the orthopedic surgeons who are treating the patients with fibrous dysplasia. So for the craniofacial article, Dr. Stijn van der Meren did a lot of work. So we also had some separate Delphi consensus meetings. Also, we really did an effort there to include some people who are not part of the consortium but are very knowledgeable in their field, because due to the heterogeneity of the disease, and also there are not a lot of active craniofacial people involved here from the medical side within the consortium. We tried to reach out to a lot of different experts as well, and I think Stijn did a great job with doing that. So we also developed some statements there and did an additional Delphi round with those particular people. And there also what we now really strongly advise not to do is that prophylactic surgery to decompress the optic nerve is contraindicated. It was also there in the previous guideline, but I think what helps with these kinds of tables, because it's also stated like this in the table, that it's more clear for people what it's meant. Because if you put it somewhere into a text, that people still think, well, they can alter a bit. But in this case, it's clearly stated it's not, or that it's even contraindicated. Also, we discussed the short courses of corticosteroids when people have problems with a rapid decline, especially to use it as a bridge to surgery. And also there, again, we think surgical scraping of contouring of fibrous dysplasia lesions as a treatment is not useful and should not routinely be performed. Of course, there might be cases that in an individual approach it might be an option, but if it needs to be done, you have to be sure that you don't do it before the end of puberty, but also not on a young adult age, because then again, regrowth is there. So there might be, for adults, sometimes an indication, but usually there isn't any, and we also advise not to do it then. So continuing on the craniofacial article, so again, you see low to very low in most of the cases with the level of evidence. So the only thing that we do see is that has a moderate amount of evidence is that in the quality of life, especially in patients in all patients, of course, with fibrous dysplasia, McCune Albright, but especially also in those with craniofacial fibrous dysplasia, should also be evaluated. And that is also, I think, something that we now also have as a separate chapter into the guidelines, that there needs to be more attention to systematically monitor the quality of life, not only for studies, but also in terms in when you're seeing patients in your outpatient clinic. So for the diagnosis part, here also again a lot of good clinical practice. But usually we give some advices, especially on how often you need to check, until what age. I think we also deliberately did that in 2 separate Delphi rounds, so that we can make some advices for children, but also from adults. Because in children you might want to be more stringent on how you're going to monitor them. Once a lesion has stabilized in adulthood, you can just broaden the terms of follow-up and also reduce the amount of radiation. Because we also saw that there was a lot of clinical variability when people will come to one center. You get yearly CT scans or yearly MRIs. And if you go to another center, there might be 4 or 5 years in between. So I think we try to give some advices there as well, so we can more harmonize the treatment and the follow-up course. So there were some things that we still need to debate on in the next revision, but we left it for this one. So especially how we have to treat scoliosis. And later on we will have an interesting oral communication as well from the group from Paris, where they also looked at the follow-up of the patients with fibrous dysplasia lesions of the vertebral column. And also for the IPMMs, I deliberately made the abbreviation because it's even in Dutch for me it's impossible to pronounce. But these are the small benign cysts that can occur within the pancreatic, the small pancreatic lesions. In patients who do not have fibrous dysplasia McCune Albright, they are considered to be pre-malignant, so there is a special surveillance system for them. But they do seem to appear more often in fibrous dysplasia McCune Albright patients. However, we don't see an increased risk for pancreatic cancer. So then it's also always the reason, well, if people are asymptomatic, do you want to screen them just to see if they have a lesion? Because then they might become nervous. They have to, perhaps, when they apply for medical insurance, they have to write down that they have these lesions. And in the end, they even might have problems with it. So if you're more pragmatic, you would say, don't screen only when you have complaints. If you are more aware, more fearful for the fact that it might in the end is a malignant lesion, then of course you might screen. So I think in the end, larger registry cohorts will give us an answer for that. And as I said, we included as separate chapters the quality of life and also reproduction and lactation, and also as a first kickoff for further collaborative studies on this part. So finalizing the talk, so we had a lot of different conversations. The guidelines are still under review at the moment, so we hope to get back to you soon with a finalized version and published version. And we also had some future research directions. So we have identified some gaps. Some of them were also already addressed in the more research paper that was also being drafted after the 2023 meeting by Mara. And we think that especially including the patient perspective in the future should really help us putting that step forward. So and if there are any questions, feel free just to ask them now, but also find me later onwards. Thank you.